My name is Brian Guetschow. I'm a third-year emergency medicine resident at Orlando Regional Medical Center. I'll be discussing our research on prediction of urinary tract-related severe sepsis, septic shock, and mortality in ED patients. Here's a list of my co-authors and co-contributors. We have no disclaimers or disclosures. Acute pyelonephritis and urinary tract infections are a common diagnosis in the ED, with UTIs accounting for greater than 2 million ED visits annually, and pyelonephritis accounting for greater than 250,000 ED visits annually. Admission decisions for these patients are undefined and often rely on subjective recommendations. There are no validated decision tools like there are for pneumonia in the PORT score and pneumonia severity index. The goal of our study was to evaluate mortality, severe sepsis, septic shock, and ICU admission predictions in severe UTIs using previously published decision rules and scores. We analyzed a practice score, Bombard score, SIRS, and QSOFA. The practice score is a modified PORT score for UTIs which was evaluated in the Netherlands and showed lower admission rates, however had increased bounce backs and readmissions. The practice score is essentially a PORT score pneumonia severity index without the chest X-ray and ABG. The Bombard score is a previously published tool for predicting sepsis outcomes. QSOFA and SIRS are two widely known and used predictors of sepsis outcomes. This study was a retrospective case control study at 2 hospitals with a combined ED census of 180,000 patients annually. We looked at consecutive patients 18 years of age and greater over a 3-year period from October of 2015 to September 2018. All patients were admitted via the ED with a final diagnosis of pyelonephritis or UTI-related severe sepsis or septic shock. Patients must have had a positive urine within 48 hours of admission. Readmissions, those patients not admitted via the ED, and prostatitis, a simple UTI, were excluded from this analysis. The European Urologic Association guidelines were used to define severe, complicated, and uncomplicated UTIs. Scores were calculated on ED arrival and the worst values over the first 3 hours in the ED. Area under the receiver operating curve were compared using the method of DeLong. Sensitivity and specificity were compared using McNamara's test, and decision curve analysis was used to further analyze the clinical usefulness of each score and net benefit for multiple threshold probabilities. We had a total of 1,011 cases, 540 patients with severe sepsis, septic shock with UTI, 471 had pyelonephritis. Mortality was 7%, ICU admissions accounted for 29% of patients, and complicated UTIs were 39%. The initial practice score was more accurate than the other 3 models in predicting overall mortality. The initial practice score was also more accurate than the other 3 models in predicting severe sepsis and septic shock. The practice score had a superior net benefit compared to all scores for predicting ICU admission at all probability thresholds. In mortality prediction, a practice score greater than 75 was more sensitive, had a better negative predictive value, and area under the ROC when compared to the other 3 models, whereas QSOFA greater than 1 was more specific and had a better positive predictive value. An initial practice score less than or equal to 75 in the entire cohort had a 1.3% mortality and only 0.4% mortality on uncomplicated infections. Uncomplicated mortality of 0.4% is similar to a PORT score pneumonia severity index class 1, which is typically managed on an outpatient basis. All patient mortality of 1.3% is similar to a PORT score pneumonia severity index of class 2, class 3. The initial QSOFA had higher specificity, however practice had higher sensitivity. As we all know, sensitivity is more important with respect to mortality prediction. Limitations of our study included this is a retrospective data collection. We excluded prostate infections and simple UTIs, and there are also multiple other reasons that patients could have been admitted. The practice score is more accurate and sensitive at a greater than 75 cutoff for predicting overall mortality, severe sepsis, septic shock, ICU admissions, and is especially accurate and sensitive in those uncomplicated UTIs subset. Prospective studies are needed to determine if practice can ultimately augment clinical judgment and be used in a broader group of ED patients with UTIs. Thank you for your time.